welcome back to Stein Fireside Chats. I'm here as always with Kai. Today he's going to give a lecture on decision-making in stereotactic epilepsy surgery.
Thanks, Brian. So I'll go through how a patient first arrives with an epilepsy neurologist, comes to our multidisciplinary committee, and ultimately winds up with one of the different surgeries that we do: resection of a brain area, laser ablation, or implantation of a neurostimulator. We'll go through things like stereo EEG and electrocorticography and their role in this decision-making process. Most of the lecture today will be focused around this manuscript that I did with Anthony Fine. For those that are interested, please find on the YouTube version a QR code where you can capture and get the paper. The basic issue that we face clinically is that a patient will come in for an initial consultation about their epilepsy, usually referred from an epilepsy neurologist from somewhere else. And we have a number of different therapies that ultimately are going to be the best for them. In some cases, that could be something very general, like a corpus callosotomy, stimulation, targeting central areas of the brain for generalized epilepsy, hemispherectomy, open surgical resection, laser ablation, targeted resection of a very small lesion, radiofrequency ablation, vagal nerve stimulation, or DBS. And we have to find the roadmap that will lead us from this initial consultation to the final therapy for the patient. And this whole process is very much a team effort. So epilepsy neurologists are involved, also called epileptologists, neuroradiologists, neuropsychologists, psychiatrists, and of course, neurosurgeons. We all meet together in something called a multidisciplinary conference, which used to be done in person, where we would all sit and look at these together. But for many centers, this is now done over Zoom once a week. And we meet and present each patient, and we talk about where we think their seizures are coming from and decide what kinds of therapies we can do about them. And so with this initial epilepsy consultation, it's performed with a neurologist. And the first thing that the neurologist does is they ask, is this patient truly refractory to epilepsy? Have all of the conservative measures, like anti-seizure medications, dietary changes, and so forth, been exhausted? And at that point, a patient may be admitted to the hospital where they have what's called a phase 1 evaluation, and that's EEG electrodes that are put on the surface of the scalp. And they'll also have a battery of imaging tests that could involve MRI, functional MRI, PET scanning, or MEG. And then with those findings, so the symptoms that they have, the imaging that they have of their brain, this phase 1 evaluation measuring electrical activity from the scalp, they'll come to our multidisciplinary conference. And the fundamental question we ask after we've made sure there's no further diagnostic workups to be done is there agreement or what we call concordance between the EEG, the brain imaging, and semiology. And semiology is the symptoms that patients have before, during, and after seizures. And in some cases, what we call seizure auras, which are miniature seizures that will cause patients to notice something abnormal, but won't dramatically change their outside behavior. And when we look at this agreement, we really assess, are all of these pointing to the same brain area? And sometimes they are, and there are some special cases of this. So if it looks like seizures are starting from both sides of the brain and from many different places throughout both sides of the brain, and perhaps really reveal communications between the two sides of the brain, we may recommend something called a corpus callosotomy, which is where we divide the two halves of the brain, or we may go to stimulation of the nervous system, either through a vagal nerve stimulator or a stimulator in the brain. And a corpus callosotomy, what that is where we disconnect the two hemispheres of the brain through their main connection. Their main connection is a set of white matter pathways that pass between the two halves of the brain, called the corpus callosum. And we can go and we can divide those two halves of the brain. There are a couple of variants of this where in the past people have either done an anterior 2/3 corpus callosotomy, preserving the posterior third of the corpus callosum, or they've done a posterior 1/2 corpus callosotomy, preserving the anterior half of the corpus callosum. And the rationale for the posterior 1/2 is that you can disconnect the areas of the corpus callosum that are transmitting activity from the areas that are responsible for movement in the brain. So maybe you can stop patients from having the primary indicator for these surgeries, which is drop attacks. That's why the whole body freezes up or the whole body goes limp and patients will fall regularly, causing themselves significant injury. For my patients, I actually have tests for this where, and many patients, their parents will come in talking about this, which is what I call the facial scar test. So if they come in and they have a bunch of facial trauma and history of facial trauma that comes from them falling on their face, those are the patients that oftentimes we're talking about corpus callosotomies up front, because the drop attack portion of their seizures, which are these episodes of either going completely stiff, which is a tonic seizure, completely limp, which is an atonic seizure, causing drop attacks, that's an indication for a corpus callosotomy. And when I do that, I divide the two halves of the brain temporarily after making an opening in the skull. And I reach down with instruments and divide the corpus callosum, making sure to preserve blood vessels that are there, making sure not to traumatize other structures in the brain. And for those on YouTube, there are pictures where you can see the corpus callosum through the corridor that I make between the two hemispheres, and the anterior cerebral artery, the pericallosal portions of it, which you have on both sides. We split those apart carefully, taking away the membranes that can cause them to stick together, and then we just go and divide the corpus callosum from an open approach. This has, in recent years, transitioned for many patients to a laser approach. Their corpus callosum has to be thick enough to be able to do this. But with this, what we do is we pass plain plastic tubes through the corpus callosum from 4 different approaches, or up to 4 different approaches, and then we burn the corpus callosum along its full extent without having to do an open brain surgery. Now, this is still invasive in the sense that we are dividing the connections between the two halves of the brain. And what we do is we place these bolts in the skull, and then we pass clear plastic tubes through them, and then we pass laser filaments into those tubes. And so there'll be an anchoring bolt that gets placed in the skull that gives us that alignment to take our tubes deep into the brain. And those are placed using stereotactic targeting systems. For some people, they use robotics. We typically use a stereotactic frame for this procedure. And that transparent tube or transparent catheter is a rigid scaffolding that we can then pass the laser fiber into. And we are able to burn structures in the brain very carefully. We do this in the MRI because we can do what's called MR thermography, but we have very special sequences that allow us to monitor temperature in the brain. And the major rationale for stereotactic laser ablation is that you don't have a craniotomy, so there's no opening of the scalp and skull. You just have these punctures, and that can get you around some of the skin and infection issues that you deal with, and also some of the footprint that you have on the head and the skull. You get around that because you're not doing that open surgery. You're not doing any retraction on the brain, and retraction means that we pull the brain to the side. And the effects of this vary quite widely by different surgeons' surgical practice. I was taught, and many were taught, to very carefully retract the brain, but then do that dynamically, meaning you retract the brain and then you let it relax, and you retract it and you let it relax, so that the brain is relaxed into place, except when you are actively performing the steps needed for that dissection of the corpus callosum. There's less risk of complications related to retraction of brain structures or the blood vessels in the brain, and patients that have the laser procedure go home much quicker and have a much easier postoperative course. Now, when we do this, the drawbacks of doing it by laser are that you have fluid spaces surrounding the corpus callosum, and those will cool down the tissue so that you will be left with small remnants of tissue that are not burned all the way through when you do this by laser approach. And when we do laser interventions, we can monitor the temperature of the brain in real time. And we initially start with just a test heating. So we heat the laser up, but only with a small amount of power, usually around 3 watts. And that lets us see the temperature change and confirm on the MRI, when we're at a safe level that's not going to permanently damage tissue, that everything is heating in the area that we expect. And then we'll perform therapeutic burns, which are typically at 7 to 10 watts. And we use pre-established estimates of tissue damage that companies have carefully calibrated to estimate where the permanent damage will be. And we can see that on overlaid maps while we're doing the procedure in the MRI. And it's a dynamic process. So usually you'll get an updated image from the MRI every 3 seconds. And then we can serially pull back the laser along that clear catheter or clear tube that's in the brain to make an elongated tube-like burn. Depending upon the type of laser that you're using, the commercial brand, you usually get something between 1.6 to 2 centimeters diameter burn, and then you can elongate that as much as you'd like along the trajectory that your clear tube is passed into. Moving away now from laser ablations, some patients who have what we call hemispheric pathology, which is damage to an entire hemisphere of the brain. Usually this is from a stroke around the time of birth, something called Rasmussen's disease, which is a progressive scarring of the brain, or something called polymicrogyria, which is really abnormal structure throughout a whole hemisphere of the brain, but leaving the other half of the brain fairly intact. For that, these patients really don't have function out of one half of their brain. And we will actually disconnect a whole half of the brain from the rest of the body in order to shut their seizures down. Now, in some people, there'll be a small amount of residual function, and we have to assess whether that's the case and then also consult with the patient and their family about whether or not that's a safe thing to do for that patient and if the reduction that we expect in seizures is worth the potential deficits that they'll have. For many people who have what we call this hemispheric pathology, for movement of their body, they'll have had reassignment of most of the brain's representation for movement of the body to the intact hemisphere of the brain. There are a number of different ways to do a hemispherectomy or hemispherotomy. Hemispherectomy is when you remove the whole hemisphere. That's rarely done anymore because of bleeding complications and other issues that people had. Usually, people will do a hemispherotomy, which is really disconnection of the hemisphere of the brain. I do something called the periinsular hemispherotomy, which is where I get into the ventricles of the brain, into the lateral ventricle of the diseased side of the brain, going through what's called the opercula of the brain, or the areas that lie over the insula to get down into the ventricles. And I'll make my way from using an open surgery from the lateral aspect of the brain into the lateral ventricle. And then I'll disconnect from within the lateral ventricle to the midline of the head. And then I'll make a few completion procedures where I follow and make sure I'm finding my landmarks. And those landmarks are things like the anterior cerebral artery that we talked about earlier. And we may undercut any element of cortex that's still alive in the Sylvian fissure along the insula, just to try to preserve the vasculature that's there to stop certain complications that can happen. Mainly we worry about things like hydrocephalus afterwards. Although I do this open now, meaning a large craniotomy where I take a large opening in the brain, there are people like Nina Maripudi in Michigan currently who do this through using an endoscope through smaller incisions from the top of the skull, similar incisions to what we use for corpus callosotomy. And then there are a few people who are exploring laser approaches to hemispherotomy, like Peter Warnke in Chicago, and I may transition to techniques like these, and I think others may transition as we see more data on them. Sometimes patients will have residual function, although the whole disease is hemispheric. This is an image of a patient we had during my fellowship in the Netherlands, where this patient had continuous seizing and movement of the right half of their body, but their speech was still represented on the left half of the brain where their left-sided movement was. So we did a tailored disconnection, removing the pre and post central cortex. And you can see that, for those of you on YouTube anyway, you can see that the steps that we took are you take away the superficial cortex, then you make your way down into the central sulcus, then you make your way around the pre and post central sulci, and then lastly, you take just the portions of the white matter that are sticking up into the gyri so that you can preserve the deeper white matter structures that are going to be responsible for transmitting speech in the brain. Moving along, sometimes the EEG, the imaging, and the semiology all agree, and they point to a single region of the brain where we can go and we can destroy it or take it out without causing patients unacceptable side effect, meaning things that won't change their personality permanently, take away their ability to move their body or speak. Examples of these would be things like focal cortical dysplasias, sclerotic brain regions, sometimes low-grade tumors, or encephaloceles. So this is an example of a laser ablation procedure that we might do for something called mesotemporal sclerosis, which is scarring and shrinking of the hippocampus and sometimes the amygdala on one side of the brain, and advance a laser bolt into the skull from two different directions. And I have one catheter that really is aimed to take care of the lateral aspect of the head of the hippocampus and the body of the hippocampus, and then another laser filament that's aimed at the head of the hippocampus and amygdala. One advantage of using lasers in these procedures is that usually heating in a region where there's blood vessels preserves those blood vessels in ways that you can't do if you do an open surgery. So you can burn higher into regions like the piriform cortex, which for those of you that are also practice epilepsy surgery, you'll be familiar with this area as perhaps a key mediator of seizures for patients with mesotemporal sclerosis and mesotemporal epilepsy. And then, of course, we do the same monitoring in the MRI machine when we do these laser ablation procedures, as I described before. We can also treat tumors in hard-to-reach regions like this one that you see here. For that, we may use multiple laser trajectories. For this child, there are three laser trajectories leading into the structure, and then we burn each of them independently And we just have to make sure in our imaging on the day of that we use a scan after the full ablation, laser ablation's been done, that shows that we've ablated that full region where the tumor is. It's important to know that you can do biopsies of these tumors stereotactically before you do the intervention. Sometimes if you do that the day of, you'll have a little bit of air and blood products, and that can impair the laser procedure that you do. And so you have to know about that and be prepared for that. So a lot of times I'll do this a couple of weeks before I do the laser ablation. You also need to make sure, either through characteristic images that you have from your MRI or biopsy, that the lesion is that you want to make sure that it's low grade in appearance, meaning it's not going to turn into something that's potentially life threatening for this individual if you don't get everything you can get maximally. This has the advantage in this particular patient's case of preserving his optic radiations and not taking away his visual capacity. Sometimes the imaging, the EEG, and the semiology of the seizures all agree, but the extent of the seizures on the cortical surface where they're generated compared with the areas of the brain that control the body are unknown. And so you really have to find a boundary between the seizure onset and an eloquent region, even though you know in general where the seizure is starting from. And we can use stereo EEG, which I'll talk a little bit about later, to do this, but classically, electrocorticography, or arrays of electrodes placed on the brain surface, really give us a good sampling of a transition between seizure onset zone in the brain and eloquent cortex, or cortex that's responsible for movement and speech in the brain. With stereo EEG, you can explore deeper structures in ways that you can't with electrocorticography, and you can sample regions that are very far from one another that you wouldn't be able to reach so easily from a single craniotomy in the case of electrocorticography. And most centers around the country, in America at least, used to do electrocorticography primarily 15 years ago. And then there was a transition that began in the time frame from 15 to 10 years ago, where most centers switched to stereo EEG, which are these wires that are placed into the brain through very small openings in the skull. And so when we do this electrocorticography with electrocorticography grids and strips, what we look for is where the seizures start from and where they spread to, and a boundary that we can get between those regions of pathology and functional representation in the brain that we usually will get by trying to stimulate to interrupt normal function. That tells us representation for different parts of function are in the brain. And sometimes we may do task-driven measurements of electrical activity and then analyze those to understand representation in the brain. And during these evaluations, there's an online discussion between the neurologists involved and the neurosurgeon. And at the time that you take that grid of electrocorticography electrodes out, you can perform a resection of part of the brain. And you can also do something that's currently off-label called constant brain surface subthreshold stimulation. And typically we'll use a 4-lead stimulator and attach that to surface electrodes. We may do something that's on label, which is stimulation with responsive neurostimulation devices. And we can actually test to see whether or not these are going to be effective through the grid at the time that patients have these grids implanted. So we do test stimulation and see if we can shut down the seizure-like activity, even if it's not producing seizures at the time of monitoring. We want to see how much of it we can shut down. When we either need to sample deep structures or we really don't have good agreement about where seizures are starting from between different brain regions, it really points us in the direction of stereo EEG or stereo electroencephalography. And that can be on one side or both sides of the head. It was invented here in Chicago with single electrodes in 1949, which I always thought was pretty amazing. Most recently, we're really rediscovering this literature, but really the development of stereo EEG as a standard practice with many electrodes came after that in Paris, France, by Taylorac and Tourneau, two physicians that were there. And Jean Taylorac was this amazing individual who actually, before he began this process during the Second World War, had provided maps, not of the brain, but of the underground in Paris to the French resistance. And he was a sort of a physician who was a real hero in the Second World War before going on and becoming a hero in medicine and developing all the techniques that people use around the world for stereo EEG now. There are some famous pictures of how he would do this, and we'll get into that in a future lecture with the Stein podcasts. This is what stereo EEG looks like. That metal brace that's holding the head is on just during the time of surgery. But you can see, for those on YouTube anyway, you can see these bolts that are placed into the skull. And I'll typically place somewhere between 14 to 18 of the leads that are there. We measure usually up to about 250 sites at once in the depths of the brain. After these electrodes are put in place, patients will be in the hospital for up to 4 weeks, waiting for them to have seizures, although you're usually there for 7 to 10 days. And we monitor them for abnormal activity throughout their whole time there. And during this monitoring period, the neurologists and neurosurgeons and sometimes neuroradiologists will have discussions about what we're finding electrically and what we're finding in our mapping. And we can then move forward with the definitive therapy, although rather than being done at the time of taking the stereo EEG electrodes out, usually we'll do it in a delayed fashion. It's much better tolerated by patients than electrocorticography is because it's really just these punctures in the scalp and skull followed by passing electrodes in. And there's typically less issues related to pain, less issues related to blood accumulation and that kind of thing that we have with electrocorticography. We'll do trial stimulation, as I talked about before, with electrocorticography with stereo EEG. And here what we do is we stimulate over 1 to 2 days different areas where we think the seizures may be starting from. And the reason why we do that is that no matter what definitive therapy that we do, many patients will still continue to have seizures. And stimulation of different brain areas is a very effective way to reduce the amount of seizures they have and how bad the seizures are when they happen. And then for some patients, if their seizures are starting from multiple different places, or they're starting from places where you can't go in and remove it, either by an open surgery or laser ablation, then you go to stimulation right away. And people will talk about stimulation of the seizure focus, which really means stimulation of cortical site. So throughout the gray matter of the brain, that forms the cortex and the limbic circuitry. Think about stimulation of that region of seizure onset. And people will also talk about stimulating brain circuits. And right now, although this is evolving, right now we really think of this as the circuit treatment for epilepsy. And here we're targeting thalamic nuclei in the center of the brain. And these are hubs of most brain circuits in the sense that most brain circuits will have a node within them that is a thalamic node. For people who have generalized epilepsy or epilepsy that starts near the sensory and motor areas of the brain, the current practice is to target the centromedian nucleus of the thalamus. For folks who have limbic epilepsy, so seizures starting from the hippocampus and cingulate cortex and that kind of thing, we'll target the anterior nucleus of the thalamus. I use a posterior approach from this, and we can look at some of the dorsal thalamic groups when we stimulate this from a posterior approach and often get very good frontal coverage as well if their seizures start in frontal cortices. Of note, as of now, really, the anterior nucleus is the only one that's been tested by the FDA for efficacy. All those studies are ongoing in the centromedian nucleus, and increasingly we're understanding that the pulvinar nucleus and its subgroups are key for targeting different cortical regions, particularly the occipital cortex and the temporal neocortex, so not the same areas as we target for when we're targeting mesotemporal structures, but temporal neocortex and parietal cortex. And so we target these three structures. Oftentimes we'll do this during stereo EEG, and we'll do test therapeutic stimulation. So we can look at seizure-like activity that happens between seizures, and we can compare the rates of the seizure-like activity, what we call interictal epileptiform discharges, and we can look at the rates of those as we stimulate different structures. And so, for example, if we're stimulating the anterior nucleus of the thalamus, we'll see a decrease in interictal discharges in limbic circuitry like the amygdala and hippocampus, but less effective reduction in occipital structures. Whereas if we stimulate the lateral pulvinar nucleus, we won't really affect the amygdala or hippocampus or other limbic structures, but we see a very dramatic reduction in seizure-like activity in the occipital lobes. We can also test using single pulse electrical stimulation. We can test connectivity between thalamic sites and cortical sites. And so we may stimulate in the medial pulvinar and find that we get a very significant evoked response or evoked potential in temporal neocortex, but we don't really get anything in the occipital cortex. And then we stimulate more laterally in the pulvinar, and now we affect occipital cortex, but we don't really see changes in temporal neocortex. And so if we were going to try to treat seizures in those two different regions, we really want to know where in the pulvinar our target should be, and for this particular patient, if they're going to benefit by having a permanent electrode put there. Sometimes with stereo EEG, we identify a region where seizures are starting from, and it's not eloquent, and we can do radiofrequency ablation. And so that's where we deliver current through the stereo EEG electrodes at relatively high power. We'll be looking at the patient as we do these ablations, And this is currently being tested with the different types of electrodes here. Currently, much of it has been off-label, but now there are devices made explicitly for doing RF ablation through stereo EEG electrodes, and we can make small burns. These are typically permanent destruction diameter around the electrodes of less than a centimeter, but they can tell us if we see a reduction in seizures that going there with a larger intervention in the form of a resection or laser ablation, that we're going to have higher likelihood of permanent cure. And then we do have some sporadic cases of permanent cure from these radiofrequency ablations. Most patients will see a dramatic reduction if we're truly in the seizure onset zone when we do this radiofrequency ablation that's lasting, even if it's not a complete cure of their seizure. And this doesn't stop us from doing any future interventions. So it's a really nice adjunct therapy we can do during stereo EEG monitoring. We then come back with this knowledge for stereo EEG studies where patients have been inpatient to multidisciplinary conference, and we may decide in very rare cases to then go to electrocorticography, but this is rare. This is maybe once every year or two out of 50 to 60 patients that we're testing. This would be the case. More often, we're looking for identification of a non-eloquent seizure focus, non-eloquent region where seizure is starting from, and then we can do that resection or ablation. Sometimes we'll do this staged. For those on YouTube, you'll see that this is a patient where we did radiofrequency ablation along the external capsule and claustrum, followed by laser interstitial thermal therapy to treat patients' seizures in a very focal part of the insula and the adjacent structures to the insula. We may do targeted stimulation or deep brain stimulation, in some cases vagal nerve stimulation. Responsive neurostimulation, which is now it's really only done with a NeuroPace device, is a device that's implanted in the skull where we record brain activity continuously and monitor for seizures. And then when algorithms that the neurologist set detect seizures, electrical stimulation will be given in order to shut seizures down. What's really nice about this, in addition to the abnormal or the abnormally identified biomarker that then stimulates to shut seizures down, is that the neurologists will also have long-term monitoring that they can use for things like changing medications and trying to optimize a patient's therapy, even beyond optimizing their stimulation. Deep brain stimulation is a term that we use for stimulating usually the thalamus of the brain in epilepsy. And it's different from responsive neurostimulation in the sense that you're stimulating at a constant rate. So there'll be 100 stimulation pulses in a second in a particular region of the brain where seizures may be starting from. Classically, this has been the anterior nucleus of the thalamus, but as I told you before, we're also targeting the central median nucleus of the thalamus and the pulvinar nucleus of the thalamus. We may have different, more evolved paradigms for stimulators now. And that can mean that we're treating nodes individually, like we talked about before, where we're stimulating maybe two different thalamic nodes, but we may also want to stimulate two regions within the same circuit. And for us, this mostly means stimulating the place within the cortex where we think seizures are starting from at the same time as we stimulate thalamic nuclei. For example, we may put electrodes for somebody who has seizures starting in the movement area and the sensory areas of the brain. We may put electrodes into the central median nucleus of the thalamus at the same time as we put electrodes into the regions of the brain related to movement and sensation of the body. The ways that we do this now sort of blend the border between off-label and on-label therapies. We find it to be very effective for many patients. And then for patients who have seizures, there is a general therapy that most patients will get some benefit from. Our current rule of thumb is about a 50% improvement in seizure frequency and intensity. And that's for about 50% of patients or more. That's the vagal nerve stimulator. And with this, that's a placement of a wire to contacts that are wrapped around the vagus nerve in the neck. And then they're connected to a stimulation generator in the chest. And that's called vagal nerve stimulation. And because so many different parts of the brain interact with the body through the vagus nerve, we can have very widespread effects throughout the brain. And for that reason, it treats a very large range of different seizure types. Take-home messages I'd like to make sure everybody gets from this lecture is that these multidisciplinary interactions between different types of physicians allows for sophisticated workup and decision-making. There is a multi-stage workup that may involve multiple procedures, some of which are purely diagnostic, like electrocorticography and stereo EEG. And the fact that we're now using stereotactic approaches rather than open surgical approaches only for epilepsy allows us, in some cases, to reduce complications, reduce the morbidity and the impact on patients' lives that the therapy for their seizures has. And again, for those that are on YouTube, we really have this roadmap that you can follow yourself by downloading this article that describes decision making. Hope everybody enjoyed the lecture on decision making in stereotactic epilepsy surgery. I'm glad that you've joined us in the Stein Fireside Chats, particularly for our educational lectures. Hope you have a great day.